Hello, good evening everyone. We'll be starting in few minutes. Around 5 minutes we'll be waiting so that the participants can join in.
It's good.
We'll be starting in another 1 or 2 minutes, doctor. Yes, Dr. Arvind, we'll be starting. Just 1 more minute and we'll start. So we'll start. Dr. Jha, shall we start? Shall I start?
Yes, let's get going.
Yes, okay. Good evening and welcome to all the veterinarians and pet practitioners across India. Vetina welcomes you all for a series of educational webinar wherein today's topic is diagnosis and treatment of epilepsy. The veterinary industry today is more dependent on human pharma for some or the other products. Hence, to enhance and uplift this noble profession, Vetina also brings to you a complete solution for epilepsy. To start with, we'll first know in brief about our today's speaker, Dr. Shanti Jha. Dr. Shanti Jha is the National Director of Surgery at Pathway Vet Alliance, US. He is a board certified surgeon and medical director at AMSC. He earned Bachelor of Veterinary Science with honors from Nagpur Veterinary College, Maharashtra, India in 2001. After BVSC, he did his MS from Oregon State University in 2005. Dr. Jha was a general small animal physician for 1.5 years in Syracuse, New York, After completing an ECFVG certification from Tufts Cummings School of Veterinary Medicine, he completed his surgical internship at Veterinary Specialist of Northern Colorado, Loveland in 2009. Following this, he completed a small animal surgery residency at Tufts Cummings School of Veterinary Medicine in July 2012. In 2013, Dr. Shanti Jha became a diplomat of the American College of Veterinary Surgeons, board certified small animal surgeon. Apart from general orthopedic and soft tissue surgeries, Dr. Jha has also been heavily trained in minimally invasive surgery techniques. He has been doing minimally invasive fracture repairs and arthroscopic correction of joint abnormalities for the last 8 years. He thoroughly enjoys laparoscopic and thoracoscopic procedures like lap-assisted gastroplexy, laparoscopic ovarectomy, laparoscopic biopsies, thoracoscopic pericardiotomy, and thoracoscopic partial lung lobectomy. Dr. Jha is also an AOVET faculty and enjoys teaching orthopedic courses in the US and abroad. His orthopedic areas of expertise include arthroscopy, fracture management of limbs and spine, angular limb deformity correction, and joint surgeries. His other orthopedic interests include joint replacement surgeries like total hip arthroplasty in dogs. At present, he is the National Director of Surgery at Pathway Vet Alliance US. We welcome Dr. Shanti Jha. Over to you, Dr.
Thank you, Dr. Tarokar, for the introduction. So what is a surgeon doing today talking about epilepsy? Being medical director and working in emergency for this long, we have to do some emergency duties and use these drugs. So I'll share my experience and of course, experiences of the other ER doctors and neurologists at our practice. Let me share my screen and we'll get going. Okay. So I think today's talk would be on epilepsy, the diagnosis and treatment. So some housekeeping stuff. I do continue to post some stuff on my Instagram. You're welcome to go and watch that. Some of the hold on. And then I'm also posting cases on LinkedIn and in some general information. You're welcome to go check that out also. So let's watch this video.
Don't watch. It's gonna go on for a while.
Okay. That is a very, very disturbing sight for a pet parent or an owner. And I'm just, it will move your ball bearings from inside when you see something like that happening to pets. I mean, it happens in humans, of course, also, but being in this noble profession and trying to make a difference in pets' life. So when that happens, we are moved, and I've seen multiple of these just coming through the door into the practice, and how we manage them, how we diagnose. This is all that story. So when a patient presents for something like that, what you just saw, is it truly an episode of seizing or behavior or something else? There are 4 questions that you have to ask. Are the events described by the owner or recorded on video truly a seizure? You must properly investigate that. And can an underlying cause be identified and treated versus just treating the seizure at that point of time? Because there's 2 different things. A seizure can be just one-off episode, or you can have a continuation of seizures every 3 months, every year, once or twice, something like that. Should an anti-epileptic drug, so AED, be administered? So throughout the talk, we'll use the term AED for anti-epileptic drug. If medical therapy is pursued, which one should you choose? What kind of AED should you choose? So I think the mainstay for the talk, where I can help you as I manage these practice here, is the experiences, what I have seen and noticed, where these AEDs have been helpful in management of epilepsy. So what are our learners' objectives? So specific history is what we are going to look into that. What are some differentials and what are some diagnostic options that you can present to the pet parents? And how do you manage epilepsy? Management of epilepsy, excuse me, will depend on the maintenance therapy. So that's why the last line is bold or bolded, which is when to start, what are owners' expectations, what are the dosages, side effects, and how do you monitor? So these are the important things we'll go over today. Not all episodes are seizures. It's very important for you need to take the accurate history, and I'll give you some examples where it will look exactly like seizures and it may not be. Okay, what are the events which caused that? There was some anxiety, some aggression, or I don't know, it was a full moon the last night, or a lot of thunderstorm, those kind of stuff. Was there any other changes in behavior that was noted? And then when they would return to normal. The classic ictal stage, this is how it looks like, friends. There's a loss of consciousness, not always a focal. So if it's a focal seizure happening right around the half of the face, you will not see dog losing its consciousness, and you can still kind of like interact with the dog, unlike the video I showed you right in the beginning of the talk where dog has no idea what's going on. Duration is less than 2 minutes most of the times. I don't think I've seen anything more than 3-ish minutes or so, and that was a bad experience for me as well as the pet. The pet parents will over exaggerate and they'll say, oh no, that has been going on for like 5.5 minutes or something like that, because they're also traumatized looking at his or her dog going through such a horrendous experience or episode. There's always a motor component, so the limbs are moving or the tail is moving in weird direction, or there is like tonic-clonic convulsions, and there is autonomic signs like loss of urine or defecation on their own. So again, there will be these 4 things you should know about a classic ictal stage. What are other episodic disorders which will look like that? And you should treat it accordingly, but not reach for something which will cause problems. So one of them is syncopial disorder. So syncope is very important. I mean, there's a big tumor in the chest and pressing on the vagus nerve, and you can fall flat on the hospital floor, and it will look like that you are having a seizure, or you have one of the adrenal tumors like pheochromocytoma with increased blood pressure. You can't stay calm, and you will have a fainting episode with some movements which will look like seizures. So narcolepsy is another one. Again, vestibular event where there is an internal middle ear issues and the dog is tilted and they're spinning, those kind of stuff. Exercise-induced collapse and pain can happen in older dogs with demyelination injury to the long nerves, for example, what we see in laryngeal paralysis dogs. And then there are those unicorns like behavioral, and they'll have just behavioral issue. You have to seek advice from a behaviorist. So that can happen, or a dog whisperer. So make sure that you know and learn about these things which will mimic a seizure activity. If you're still not sure, use your iPhone or any kind of phone you have and download some apps. Educate the pet parents that they should take video. Most of us are sitting on our phone or have our phone ready when these things happen. In the first video, when the lady or the pet parent kind of like kneeled down to pet the dog, you saw there was a phone in her hand. And of course, the husband was taking the video. So technology can be your friend. So video is something very important. So educate your clients, the pet parents, to take videos, and you can watch that whole episode in slow-mo and make a guess if this is truly a seizure activity or something else is going on. There are 3 classes of seizure disorders. We will dissect them so that you will know that what causes them and how to treat those things. And then we'll focus mainly on primary idiopathic seizure. So There's structural. So basically, when I say structural, that means that there's something going on between the ears or, in the brain. So reactive, where the brain is normal, there is nothing going on there. However, dog got into some kind of toxin, which could be drugs, or has some metabolic issue, something with kidney, where protein is not processed well, or the liver, which is releasing a lot of seizurogenic molecules. And then the last one, the big guy, is primary, which is idiopathic. Idiopathic is basically genetic. So let's look at structural. When I say structural, that is basically a tumor in the brain. So there are multiple studies that you can go through to get an idea what are those tumors and when they happen. This is beyond the scope of this lecture today, and when they're affected and how to treat it. There's one article right here, which is MRI features of canine intracranial neoplasia, published about like a decade ago or so. It's a good study where they talk about tumor diagnosis and classification. So us as veterinarians, learning is always there. So you should keep learning. I still do. I still read articles, and that keeps me going. So that's structural. Second one is reactive. When I say reactive, that means that reaction is happening in the brain or central nervous system after an insult by these things. So there could be anything like from drugs to alcohol to a poison. Some of them would be right here, like tobacco, or a recreational drug like marijuana or aspirin. Metronidazole can cause that. At times, we humans are in depression, and there are some antidepressant drugs, and dogs can get into that. They're smart, unfortunately, and you can have reactive reactions. And the third class of seizure disorder would be primary or idiopathic, where unfortunately the dog is born with something like that, where the protein and mRNAs are causing this, where brain is almost normal, but it will just continue to increase electrical activity, and then your dog will have these kind of seizure episodes. So seizing episode, again, will start around like 6-7 months, and you'll probably see a few or a bunch until the dog is about like 6 years, and after that it can be pretty regular. So it's our job as veterinarians to make their life a little bit better, and that's one of our oaths. Okay, so history and signalement, as I mentioned, super important to collect a proper and accurate history, use the technology. So the age is important. Now, if a dog is about like 12 years of age and comes to you with seizuring activity, the first thing you'll probably be thinking about a structural problem inside the brain, like a brain tumor, or something else in the body, like a tumor in the lung or in the abdomen, which is causing weakness, which can look like a seizure activity, but not idiopathic. So age is important. Onset of seizures, so is it single? Is it cluster? Is it status? And then, of course, focal versus generalized, because they can also differentiate how you treat those things. Historical illness, hypothyroidism is known to cause these things. So always run a thyroid panel. And chronic kidney disease, again, we talked about the protein losing nephropathy. And then recent behavior changes, which can tip them over to get these. So again, aggression, anxiety, or addition of something else at home or some other member. These can tip the dog to get into seizure activity and then can turn into epilepsy.
Dr. Jha, sorry to interrupt. Your voice now, you have to either increase the volume of your device, because the voice is not clear to some of the people. Maybe there is connectivity issue at their end, or there is the volume itself is low.
Okay, let me see. Hold on.
Yeah, somebody's saying it's clear. So just maybe it's the connectivity issue at their end. Dr. Tapesh, it might be a connectivity issue at your end. Yes, doctor, continue. Please continue.
Okay, so just please interrupt me if the participants cannot hear it properly. Okay.
Yes.
Is it clear right now?
Yes, it's clear. It's clear.
Okay. So neurologic exam is the mainstay for diagnosing seizure and then getting you towards the diagnosis of idiopathic epilepsy. So very confusing, and there is a gray area. There's no black and white. In medicine, there's no black and white. So what is it? So if the neurologic exam is abnormal, there's probably structural and metabolic stuff going on. So when I say structural, that most commonly it's uni-sided or not like symmetrical or not both sided. When it's metabolic, it's probably toxins. So toxins do not pick a side. So you will have both sides affected. And I'm mainly talking about the cranial nerve exams. If it is normal neurologic exam, you can still have structural and metabolic stuff that you don't know at this point of time. However, most likely it will be idiopathic. So how do you do a neurologic exam as a entry-level veterinarian or even a specialist like me? I do neurologic exam on almost every single dog walking in. Being an orthopedic surgeon or a general surgeon, I have to make sure the dogs do not have any neurologic component because you shouldn't be treating an orthopedic case if the dog has an overshadowing neurologic stuff going on. So this is how I do it. And again, picked up from open source. You can watch these videos. It's one of the neurologist's friends here, Rossi House.
The neurologic examination can be broken up into 6 simple steps: evaluation of mentation, gait and posture, the cranial nerves, the postural reactions, the spinal cord reflexes, and finally, evaluation of nociception if appropriate. Each portion of the exam should be performed in order to properly localize the problem.
Okay, so you start with mentation. I'm not going to go into full detail because, again, we can do another lecture where I'll show you how I particularly do a neurologic exam for orthopedic versus neurologic condition and cranial nerves. But give you an idea that make sure that you know properly how you have to do a neurologic exam to get to the base of what is actually causing this. Once you've done the exam, immediately I will order CBC Chem, which is minimal database. Now, complete blood count will tell you about if there's anything else going on. Often normal, if even if it's infectious or inflammatory, just because it has not shown in the blood. Chemistry will rule out metabolic and concurrent disease. So definitely super important because you can rule out kidney and liver stuff right away, or hypoglycemia. I mean, the other day I was walking into a clinic and I saw a tiny dog seizing. When I say tiny, it was a young dog, 12-week-old dog seizing, and they're trying to reach out to grab everything and running all the tests. One of the questions I will ask, like, what's the blood glucose, right? So it's so important. So do not forget the basics. CBC Chem, UA are the important tests that you should be doing. So minimal database. So UA, again, baseline renal function, culture, or protein losing nephropathy should be ruled out. Now, funding exam on the a retinal exam is important because there are conditions where you will see there's the detachment of retina or there's fungal plaque. So it's important for you to be a well-rounded veterinarian as well as a well-rounded ER doctor who's going to treat and triage these cases to do a nice funding exam. Nothing fancy about this. You just need a funding lens and a source of light to do those exams in veterinary medicine in our dogs. Blood pressure, again, every single dog, that should be something what is should be a standard of care as it is in human medicine, and we have to do that as veterinarians. So blood pressure should be measured on every single dog walking in. Most of the times it should be less than 160. If it's more than that, and I'm talking systolic, then you should think about, like, is there a pheochromocytoma which is causing this? And then you focus more on the ultrasound and abdomen and this and that. So again, a well-rounded diagnostics. We're not done with diagnostics yet. So immediately I'll take a thoracic imaging just to rule out lung tumor, mediastinal mass, and lymphadenopathy. Do the same thing for the abdomen where you're ruling out liver or kidney tumor, metastatic mass, and again, lymphadenopathies. Then you'll submit the test for infectious disease. So I'm hopeful that there is test back home for tick panel or tick-borne disease. Here in the United States, it's very common. So we send out PCR, DNA, serology, those kind of stuff to rule out infectious diseases in dogs and cats. And then comes, shall we take a CSF and analyze it? So cerebrospinal fluid analysis, should we do it or not? When you're running through these diseases and you're not finding anything, at times a neurologist or a surgeon will recommend to get that done. So yes, it's an easy test to do. And even it is technically easy, there are some cons, which is you have to have anesthesia, and there is some risk of intracranial pressure to be increasing. And this test, you need a prompt analysis. One thing what I have noticed is that you can run the fluid analysis of CSF. However, just looking at the protein and bacteria and neutrophils will not give you a definitive diagnosis. So definitive diagnosis, in my mind, in my experience as a boarded specialist, still has been rare. So shall we do it on every single patient? It's debatable. This is how it's done.
And we use the needle with specific landmarks to collect fluid. So we let the fluid just slowly drip out. You can collect it into a tube, or as I'm doing here, I use a syringe to collect it drop by drop.
Okay, so you can definitely collect it and send out. So then the last couple of things would be two big ones would be MRI and CT scan. And there's a neural patient, you can't run away by doing advanced imaging. And I'm fortunate that I'm working at a hospital where I have both of them, and we can definitely look at those. So MRI is the mainstay where you would have a high sensitivity, so you can rule out a lot of things at an early stage. It's a 3-plane imaging, preferred for soft tissue disease, and there's no radiation exposure, so pretty safe. CT scan, so this is how an MRI image looks like for dog. CT scan is less expensive and shorter anesthesia time, preferred for bone, and again, minimal metal artifact. On MRI, if I have a dog who I have already repaired a fracture or something, let's say a lux, where I put a couple of screws to fix the atlantoaxial joint, that's not a good candidate for MRI just because of the magnet. So in CT, we can definitely look at those. However, important one in CT is if there's a tumor of skull, for example, there's a chondrosarcoma of the frontal or temporal bone, which is actually pressing onto the brain inside and causing these seizure activity. So CT is another important one. Most of the times we'll run with the MRI and you can still see some bony changes. And if it needs to be confirmed, then we will get the CT scan done. Well, before we do the treatment, let's go over the definition one more time. I just want to make sure that I've drilled down this to ourselves and budding veterinarians, hopefully some students are around, is these two things, seizure and epilepsy. So seizure is a burst of uncontrolled electrical activity between brain cells that causes temporary abnormalities in muscle tone or movements, behaviors, sensations, or states of awareness. Again, burst of uncontrolled electrical activity with muscle movements. What is an epilepsy? Epilepsy is the big guy above seizure. So what is happening in this is defined as 2 or more seizures at least 24 hours apart, resulting from non-toxic, non-metabolic cause. So that would be your epilepsy. So again, seizure could be because of many reasons. In epilepsy, you're trying to rule out other things, most commonly idiopathic. So what are our treatments? Okay, what we'll do is we'll divide that for seizure, just a few slides, and then epilepsy, the big guy, the talk is for the epilepsy here. So in epilepsy, we'll talk about the chronic management. In seizure, let's see what we have. So I was doing this talk, revising this talk about like 2-3 days ago or so. And coincidentally, one of my colleague, young doctor, he came and he was like, "What are you doing, Dr. Jha?" And I was like, "Well, I'm just gonna give a talk on epilepsy and just doing my slides." And he's like, "Well, what a coincidence, because I'm, as you said, I'm also revising the protocol for our hospital, the hospital I work here now, Pet Specialist of Austin." So he was showing me the protocol, which of course I have to approve, and it has to be rolled out to the whole department or whole hospital. So what is his protocol? Let's look at this. Okay, so again, it's an immediate treatment for seizures and status epilepticus. So forget about the $400 for critical initial codes. You can charge whatever you are charging ethically and morally is correct. So what our ER team is going to do is place an IV catheter as soon as possible. It's not necessarily that you have to do that. A modification would be just to put a butterfly or skip the IV catheter if patient is seizing that much. Check the blood glucose. I think this is one of the most important one that you should be doing. Most commonly now what we are seeing is young patients. So that's why this is a little bit modified towards blood glucose. And if it's less than 60, they're going to give 50% dextrose. If there's no IV catheter, you can just like apply dextrose right onto the gums. That should solve the problem. However, if blood glucose is normal, then you know that it's not the glucose which is causing this, and it is seizing, and you need to fix that. So just basically stop it. Our protocol for now, right now, is choosing midazolam. However, my favorite is diazepam, which has shown a lot of I would say repeated success. So I normally use diazepam, which is Valium. So in this case, you can always give like 0.25 or quarter mg per kg of midazolam IV. So that was his protocol. But here's what I would recommend that you should have is Valium. Valium is your friend. So basically it is a diazepam. You can give it rectal, which is 1 to 2 mg per kg. Higher if the dog is already on some kind of anti-epileptic drug. So you know that it's a known patient coming to you, has been on Keppra or levetiracetam, and you have to give more of the diazepam. So basic idea for giving diazepam is IV. So here, I'm going to throw some numbers at you and you should note it down. Is if you have a diazepam, which is 5 mg per ml. So look at the bottle, which it says 5 mg per ml. If you have that concentration of diazepam at your clinic and you see a seizing patient coming in, it's a small dog or a cat, just give half ml IV, period. No questions asked, just give half ml IV. If it's a big dog like Labrador, Golden, Pit Bull, those kind of dog, big boxer, give 3 to 5 mils IV. Don't worry about calculating. It comes out to be roughly around that area. So dosage is 0.5 to 1 mg per kg. You may repeat that, or you can just substitute midazolam IV, which I discussed with you. And the preferred dose is 0.25 mg per kg, which the young doctor's protocol, which I was showing you. So what is a diazepam? It affects at GABA and it will cross the blood-brain barrier very quickly. You can give multiple routes. IV is the most common, and very, very short half-life is one of the disadvantage, and it is caustic. So if you're not giving properly, it will cause problems. And there's some increased price at that point of time when you're saving a dog. I'm not gonna wait for like 50 or 100 extra dollars. We will save the dog first and sort out the pricing later. So that's my approach. Okay, so there has been some study. I think I should just throw that to you. Let's say that the IV is not possible. Maybe all the nerve veins are not that properly that you can put an IV catheter, or you're poked multiple times and dog is seizing, then what? Well, there is a study which was done 10 years ago or so about intranasal administration in dogs, and it compared the pharmacokinetics of IV versus intranasal. So dosage was 0.5 mg per kg, and it of course took a little bit longer to be effective. However, it was better than the rectal. So remember, the rectal is 1 to 2 mg per kg. This is 0.5 mg per kg. So higher bioavailability compared to rectal. So intranasal. And then again, some other study reported 80% in 2000, but the newer study, this one was like 42% bioavailability. So that is another thing what you can do. So if it is still seizing and you're still trying to find a balance there, repeat the dose, totally fine. Or put that dog on a diazepam CRI, which is 0.5 to 1 mg per kg per hour. Constant rate or continuous rate infusion is indicated. So you can do that. And you can put through the central line or just normal IV catheter. Remember, it's a light sensitive drug. That's why you see that in a brown bottle right there. It binds to plastic, so glass syringes, something like that. If it is still giving you problems and you can't control it, then the final thing what you will do is a CRI of an anesthetic. The best one so far is propofol. So first you load that with 2 mg per kg and then up to 0.2 mg per kg per minute. However, you need to have an oxygen support. I normally intubate that and more intense monitoring. I remember about a decade, 7-8 years ago, I had done a portosystemic shunt surgery and placed an hemorrhoid constrictor to clot, slowly seal the shunt. And the dog went into seizure activity, which was refractory to diazepam and multiple boluses. I had to put that dog on propofol, CRI for straight 8 hours. Dog walked home after that. However, that was one of the rare good positive things what I got from that episode. So when you're gonna do propofol CRI, things could be a little dicey and other things, underlying cause could be going on, which you can't control. Okay, so you were able to control the seizure. So now what? Well, first of all, give yourself a pat on the back that at least you have controlled the seizure activity. The brain cells are healthy. They're not dying underneath, hopefully. So here is the important thing what we have to find. Now we'll reach out for anti-epileptic drug. After, of course, you've done the more history and run all the tests and you've decided that this is an idiopathic incident. It's going to be probably idiopathic. So the importance of administering anti-seizure medication on a regular schedule is key. So pick 180 and make sure it's consistently given to the dogs. If it's a BID or TID, make sure the pet parents are giving it properly to the dogs. And don't just change it right away. It will be effective only if you stick to that. Give at least 2 to 3 weeks. So let me remind you again, pick one and stick to it. Whatever is beneficial for that dog, as well as how you can get it. Vetina has some good products and we'll discuss that. And if it's cost effective to the dogs. Okay. Now, the later half of this talk, we will be talking more about treatment and how to maintain those things. One of the papers I pulled for all of you right here is published in 2014. So just like 6-7 years ago, which is Treatment in Canine Epilepsy. It's a systematic review. It's basically a meta-analysis of all the papers, all the drugs, all the research so far has been done on different drugs, from potassium bromide to Keppra to zonisamide to gabapentin. Talks about the efficacy of AEDs, and a lot of studies has been combined into this. And I pulled some drugs out of this study and we'll discuss those. So here's the most important what I have seen in my practice and in general in the United States is phenobarbital still used a lot. Potassium bromide, another one, and then levetiracetam is a good one. You can do solely or you can add on. I normally prefer just solely. Zonisamide is a newer one. We don't know the mechanism of action, but works great. And then other AEDs, the most important one would be gabapentin. So let's go discuss those things. Again, AED would be anti-epileptic drugs. So when is AAD drug therapy recommended? So when any of the following are present, there's structural cause for seizure. You know that this dog has a small brain tumor or a big brain tumor, and you know that the dog will have seizure activity and you can't predict it. So just put that dog on AAD. Or if it was a very, very severe first seizure, or you're still seeing the post-ictal edema, so then put that dog back onto that. Or, you know,
Sorry to
yeah.
interrupt. Dr. Arvind has asked to repeat protocol of seizures, including emergency also, emergency treatment.
Like the slide what we just showed.
Yes, yes.
Okay, let's go over that again. So it's very important for all of us to understand, and thanks for that question, Arvind. So the treatment starts at seizure and then versus epilepsy. So let's get that again properly drilled down here. So seizure is immediate treatment and epilepsy is maintenance, okay? So again, 2-3 days ago, I'm finishing up this talk and this young doctor comes to me and he's like, what are you doing, Dr. Jha? I was like, well, I'm just making sure that we have a proper seizure epilepsy talk. I'm teaching some veterinarians back in India. And he's like, well, what a coincidence. I was just doing that also for your approval. And here is his immediate treatment for seizures, or our pet specialist of Austin. So I'm going to pause for a few seconds right here so that you guys can note it down. So again, place an IV catheter. If you don't have an IV catheter, a butterfly cannula is completely fine, or just we are all, I know one of the Indian veterinarians are amazing. They have amazing talent. Just use the IV with the syringe straightforward. Check the blood glucose right away. Make sure it's not the hypoglycemia which is causing it, and then be ready with midazolam or diazepam. My preference is diazepam, but you can use midazolam at 0.25 mg per kg depending what you have. So here's what you have to do. So again, Valium is your friend. Valium is your diazepam. So I hope you have a 5 milligram per ml bottle, or you can calculate the drugs again. But let's say you have technically 5 mg per ml bottle. If you have a small dog, just tell your technician or your nurses to pull 0.5 ml. Give that small dog or cat that kind of diazepam, that Valium. If it's a big dog like Lab or Golden, give 3 to 5 mils. Just pull 3 mils straightforward and give it. And then you can also give this rectal, which is 1 to 2 mg per kg, or intranasal 0.5 mg per kg. So again, IV is the most common thing what we do with diazepam, and it is the mainstay of stopping seizure activity. You may repeat that, or you can substitute that with midazolam as we discussed. So less effect on liver, I guess. That's why midazolam. So midazolam is 0.25 mg per kg, but diazepam is again 0.5 to 1 mg per kg. So we're not going to go through, we just went through that, but let me quickly go through intranasal. So the studies were done if you can give it intranasal or not. Rectal is good. You should be able to give rectal, but if dog is like defecating as you're trying to do rectal, it's kind of a little iffy. So intranasal is another route that you can choose, and they compare the pharmacokinetics of IV versus intranasal, and it was effective in 40-42% of the dogs. So let's say if it's still seizing, you've given one dose and still seizing, what should you do? Put that dog on the CRI. When I say CRI, which means that 0.5 to 1 mg per kg per hour, just dilute it or just straight via central line, give that dog the continuous infusion of the diazepam or Valium. And if that fails, then you're gonna reach for the anesthetic drug known as propofol. So I have used it to my success. And again, it's a last resort. When you're using propofol, you're dealing with a bad critical case. But here's what the dosage are. So in diazepam, see, there is no like loading, which is 2 mg per kg to effect was there because we've already given diazepam. So when you're reaching for propofol, you have to load that patient with 2 mg per kg to effect, and then put that dog on 0.1 to 0.2 mg per kg per minute of CRI. And of course, you have to give the oxygen support, intubate, and assign a technician to monitor. It's just basically keeping the dog below the surgical plane. So not to the surgical plane, but just a simple general anesthetic plane. You're not, seizure is still happening in the brain actually at that point of time, still, if that is the case. So that would be the emergency treatment. So let's say if you have controlled it, so we discussed this. Now the idea is to pick one AED. There's no need to throw like a bunch of AEDs right away. Okay, so this is the study I was talking to you guys about, which is Treatment in Canine Epilepsy, published in 2014. And it is an open source available to anyone. BMC Veterinary Research 2014. You should be able to download this and read it. The important drugs is anywhere from pheno to potassium to Keppra to zonisamide to gabapentin, and we'll discuss those. AED, when I say AED, which is anti-epileptic drugs. Okay, so when should you start that? When you know that there is a structural cause, and when you know that the seizure was very, very severe, and the owner preference is that, yes, please start, you should definitely ethically and morally put that dog on AED. Now, there's some general rules. How do you do that? So I normally do not put them right away on AED if I've seen only one seizure activity and then patient's history and signalement do not match for idiopathic epilepsy. So I see that, okay, if there's 1 or 2 seizures in 6 to 12 month period, due to these reasons, I'm gonna put them on AED. So what are those reasons that I think that we should start doing that? Seizures are life-threatening condition. So that can definitely cause death. And if you know that if you have to reduce that, put them on AED. The pet parents or owners felt the only acceptable seizure control is 0 seizure. So they want that this dog should be on AED. Please put those dogs on AED, very important. There are many drugs, and I hopefully Vetina will give you some insight, but there's many drugs with least amount of side effects nowadays. They're known as newer AEDs that we can use it properly to control this horrendous disease or horrendous manifestation of disease. So again, new generation AEDs have not a lot of side effects, which is good. Remember, every single time a patient has seizures, there's definitely an increase in another seizures. So what happens is that you have a seizure, some brain cells die, and then you have another seizure, some brain cells die. So that keeps happening and repeating this vicious cycle. So what are those anti-epileptic drugs and how do I use it? How does our hospital use that? Let's discuss those. I pulled some from that same paper. I recommend that you guys should study that paper thoroughly and then choose according to the patients and owners and your needs. So let's talk about phenobarbital. The mainstay has been there for ages. So it potentiates GABA activity and hence it controls it. So effective in 60 to 80% of idiopathic epilepsy patients if it is in therapeutic range. So what are those? So 2 to 3 mg per kg PO/BID or 1 to 2 mg per kg PO/BID in cats. Again, in dogs, you can use this 2 to 3 mg per kg PO/BID. But this drug actually comes with a lot of side effects. I'm not going to say a lot, some substantial side effects. So you can have sedation or you can have hyperexcitability or restlessness. You can have PU, PD, PP, liver enzyme induction versus toxicity. You will see that ALP, I think it's SGOT or something like that. I've forgotten the terms back home. So ALT, ALP, and GGT will increase. And basically this drug can slowly burn the liver. So be very, very careful. So how do I monitor? I'll put them on phenobarbital and then initial check at 2 to 4 weeks after initiation. So half-life is about like 90 hours or so. So the target is about 15 to 40 microgram per milliliter. So my personal preference, if it is less than 35, I'm totally happy with that. And then we recheck every 6 months. Of course, concurrent CBC chemistry should be done just to make sure that the liver is functioning well. And at times you can do bile acids, because bile acid is the function of the liver, how the liver is functioning. And recheck like every year, totally fine. Now, phenobarbital has a weird relationship with thyroid, so it's important that you should do the thyroid level check, because thyroid is one of the main organs for BMR and homeostasis in general in the body. So make sure that you run the T4s and free T3 ED, those kind of things. So with phenobarbital, there's increased elimination of thyroid. So you shouldn't be thinking about the opposite of euthyrotic thyroid syndrome. So there is increased deiodination, those kind of stuff. But again, the idea is to monitor the thyroid with phenobarbital. Okay. The next one we'll discuss is potassium bromide, one of the common drugs that I've seen used here, which is basically simple to give as a tablet form. So what does it do? Very simple. You have competes with basically the NaCl channel. So it competes with chloride transport. Bromide just sits there instead of chloride, and you don't have neuronal hyperpolarization, so not excessive activity, hence no seizure. So basically that's what it is in simple terms. Improves the control in 70% of phenobarbital refractory idiopathic epilepsy. So your dog has been on phenobarbital and it's not helping, then slowly wean it off and then put that dog on potassium bromide. And I'll give you the stages or some points how to slowly wean a dog off of a AD and put another one. So just don't cold turkey stop one and then put it on a newer drug. That will cause a huge problem. So the loading dose is 400 to 600 mg per kg over 3 to 5 days. And then you maintain that if you're doing just monotherapy, which would be 40 to 60 mg per kg SID, or if you're still adding it to augment phenobarbital, that will be 20 to 40 mg per kg SID. There are some side effects, of course, hyperexcitability, restlessness, similar kind of thing. But in cats, it is contraindicated. You shouldn't be reaching out for that because 40-50% of them will have some issues with eosinophil in the bronchus, and cats already prone to get asthma. We should not reach out for this drug. How do you manage or maintain that? Half-life, roughly 24 days. So initial check, roughly about 90 days after you have done that. And then every 12 months or 6 to 12 months, just pull the levels and combine that with your phenobarbital level. The newer drug, which is zonisamide, has been used here. We don't know yet. There's some more research coming out how it works, but 60% efficacy in idiopathic epilepsy in dogs, and we are talking mainly monotherapy. When I say monotherapy, that means there's one drug being used. And remember the rule, pick one AD, and then if it's not fixing your problem, then you think about adding another one slowly or taking completely off and add a different one. So we'll talk about those. So initial dose for zonisamide is 5 to 10 mg per kg, POBID. Higher dosage if you're using this with phenobarbital. Here's one thing about these all AADs that you can mix and match. I will recommend, please don't do that, and see if you can just use one and wean that off and add another one. And if it's not helping you, then you think about adding the two together. So that would be our approach. So there has been multiple studies, one of the older studies done in 2008, which looked at the pharmacokinetics of zonisamide and drug interaction with phenobarbital. Nothing so special, so you should be able to use that. It is like a sulfa drug, a little bit more different. However, it causes dry eye, so be cognizant of that. It's still debatable, and you can use that in cats. So one of the drugs easily used in cats. It can cause acute hepatic necrosis also, so just be careful about that. So a couple more studies quickly. Apparent acute idiosyncratic hepatic necrosis associated with zonisamide in dogs, and then if you can use this as monotherapy or not. And they both like showed that yes, you should be able to do that. However, there is some chances of getting hepatic necrosis. So I just put this slide. It's still debatable that do we see this dry eye with zonisamide all the time or not. So basic idea is just monitor and kind of like fiddle with the dosage, what to do, what not to do, decrease or increase depending the control of epilepsy in that dog. I don't know where back home these tests are done. I'm not sure if it's done in Punjab or Mumbai or Bangalore, or who knows where. But here there's only 1 or 2 universities that we can send the levels to. And one of the important one is University of Auburn, where we send all these levels to be checked. One of my favorite drugs is levetiracetam. It's known as Keppra. I'm going to share this story. When this drug was being researched here, I was fortunate enough that I was able to interact with the donors who were giving money for the research for this drug back in 1990s, but I met them only about a few years ago or so. But anyhow, so we call this drug here Keppra. It's one of the easiest available drug here in the United States and has shown amazing amount of promise treating idiopathic epilepsy, or epilepsy in general, we'll say. So let's look at levetiracetam. So very interesting drug. Mechanism of action, again, it acts in between the synapses. So very proven theory, how it acts and impedes the conduction around across the synapses, like aspromazine. And the initial dosage is 20 to 30 mg per kg, POTID. And these are coated tablets, so you cannot divide them. You can't split it. Here in the United States, I'm not sure about the product from Vetina. Hopefully we'll get some more information on that. But they come at 500 and 750 milligram tablets, sometimes too large for small dogs and cats. One study done, and this is a placebo-controlled intravenous IV study done for the treatment of status epilepticus in dogs for repetitive seizures. So Keppra, again, it's a levetiracetam. So they use in 19 dogs, and it was a randomized placebo-controlled, and they found that after you have given diazepam, and if this drug was given, there was 100% control where there was no seizures post-study, so which was a good one. No adverse effect was shown with the IV given. Some side effects, which would be sedation. One of the most common side effects that you can tell your pet parents is sedation for almost all the anticonvulsant or anti-epileptic drugs. That is the way they kind of like they slow it down, and it will cause some sedation. So in cats, we see a lot of hypersalivation. Nothing to be worried about it. However, you need to maintain that. They may suppress a little bit of like adrenocortical axis, but I'm not too curious about that. So monitor the renal excretion. So USG and renal panel should be done every 6 to 12 months just to make sure that kidneys are still able to handle Keppra and releasing it properly. So again, we send it to University of Auburn to estimate levels. So that was your levetiracetam. So now last one, I'll just quickly go over this, is gabapentin. Gabapentin is an interesting drug, readily available here. At times it's abused here also, or anywhere it can be abused, but very, very important drug. And I use that very frequently. Almost all the patients here I see. So it can control pain as well as an amazing anti-epileptic drug. So just quickly, it just decreases the neurotransmitter release. So gabapentin or pregabalin, those two similar way of action. And it's excreted through urine. So check the urine function every 6 months or so. Dosing is 10 to 30 mg per kg post-op TID. And half-life is about like 3 to 4 hours in dog. So hence I do like every 8 hours. So what happens with this is dogs can get quote unquote addicted to this drug, so you cannot just stop this drug. So if you have to wean the drug off, if you have to stop that. So basically, if you're giving gabapentin for a long time and you have to think that now we have to stop the drug, start reducing the dosage and frequency over the course of a few weeks or a month, and then remove it. So some side effects, especially we see that if it is compounded in something known as xylitol, and you know that is not a good sugar for dogs, doesn't happen anymore. Sedation, possible withdrawal, seizures. So sedation can happen. Many of the dogs, when I do surgeries, I'll send those home on gabapentin also. It's a good painkiller, and the dosage is about like 10 mg per kg. But to control status epilepsy, you should use higher dose, so up to 30 mg per kg or so. Pregabalin, similar kind of thing, 3 to 4 mg per kg. So we discussed a lot of anti-epileptic drug. Now, a few more slides to just clear a few things here. Some reasonable guidelines. Of course, we are all doctors, we are all veterinarians, we are all going to go study and make sure that we have a proper plan. These are reasonable guidelines, and you can change these things. But here's what I would suggest. Use 180 at a time. Which ones? Choose that which has the best efficacy, lowest cost, and lowest dosing interval, fewest side effects, and lowest risk of toxicity. So this would be your general guideline for choosing AD. Whether you're going to choose a gabapentin or levetiracetam or phenobarbital, it's up to you. Up to you, to the pet parent and the dog. And three of you guys will decide, of course, looking at the dog, where the dog is, how the liver enzymes are, how the kidneys are, how his general mentation is. You're going to pick that. So I'm going to pause one more second for that. Use 180 at a time. Which one do you use? Which one at Dr. Jha's practice, or what I have seen has been very common? So you've controlled the seizures, you know that's an idiopathic epilepsy. This is where I go. And it is on the level where the first one is the calmest one that I'll reach for. Keppra is the drug. So levetiracetam is the drug that I'll be reaching. And the dosing is right there, 20 to 50 mg per kg, POQ 8 hours. That will be my first one. Then if it's not available or the dog has been on that, then I'll pick up zonisamide. If not, then I'll do gabapentin. Then the last one now is phenobarbital or KBR. However, you can pick any of those and that should all help. But I've been a big fan of levetiracetam and gabapentin in the practices I've managed or seen or be a part of. So you've already put that drug, dog is doing well. What if in 3 months, dog is not still controlled and it is still refractory? When I say refractory, that means you still have seizures happening. So there's increased frequency and severity of the cluster. So what you do is you increase the dosage of that drug first. So if you are putting that dog on levetiracetam and you're doing, let's say 25 milligram per kg POBID, do 30. Increase the dose first, okay? Making sure there's less of the clinical side effects. If still not doing good, then when you should switch, give at least 2 to 3 weeks before you do that, and then start to reduce the reduction, making sure there's no other concurrent illness. So we'll go over that again, and I'll give you some rules and timelines, how you should switch it, and I'll pause for a few seconds so that you can write it down. So when to change an AD? When there's a lot of side effects and there's lack of efficacy, then you should go ahead and change it. So the first 2 points, side effects, lack of efficacy, and dog is still having seizures. Okay. General recommendation, use 180 at a time. Therefore, ADs often need to be switched rather than added. Of course, you can add it. There's no argument that you shouldn't be adding it. However, the preference nowadays is that if you want to switch it, that will give you a better result because that gives you a better control. There's less of a confounding factor. Which one is working? Is it potassium bromide working? Is it gabapentin working? Is it Keppra working? Or is it barbitol working if they're mixed together? So the preference should be is to keep things simple in our lives and in dogs and pet parents' lives. So use one AD at a time. So there are some research studies which have shown that you can use a new generation AEDs like pregabalin, levetiracetam, or niacinamide, and add it to phenobarbital or potassium bromide, and you can have a good result. However, if you add saline to these guys, you have the similar kind of effect also. So placebo, it doesn't quite get you there that the two together will have a fantastic result. So again, sticking to one AD should be something what I would propose. However, you should do your own study also. So here's how you transition. Again, very important slide. I'm gonna go slow so you guys can take some notes. Okay, for 1 week, add the new AD to the patient's current regimen. So let's say the patient is on, for example, Keppra or levetiracetam and still a little bit iffy. So just add gabapentin to that for 1 week. For the next 5 days, reduce the former AD by 50%. Next 5 days, reduce the frequency. And after that, you can discontinue the former AD and then continue the newer AD, which is already for in the system for last 15, 17 days. Okay, let me repeat that again. For first week, add the newer one, the new AAD. So let's say a drug X and drug Y. So dog is on drug X. So add drug Y for 1 week. For the next 5 days, reduce the dosage of drug X, continue drug Y. The next 5 days, reduce the frequency of drug X, continue drug Y. And then after that, completely remove drug X, and now you have just the drug Y. That's how you slowly introduce the new drug. If you just stop and go ahead and introduce a new drug, the chances are that there could be withdrawal seizure activity, a little harder to control. There's some other types of therapy you can give. Again, we have discussed intranasal, sub-Q, intramuscular, rectal. We're not going to go through that. We've already discussed that. How about nutrition? There's some report that omega-3 fatty acids have possible anti-seizure effects, decrease hyperlipidemia, and then taurine, one of the amino acids, possible anticonvulsants. Sure, they could be added, but in allopathic medicine, we'll have to rely on these drugs to cease these seizing activity. So in summary, at the present time, there's no cure for epilepsy and treatment is focused on seizure control. That's what the mainstay of this talk was. It's important to understand the potential side effects associated with a medication. You should study it. You should let the pet parent know that these are things which will happen, and then work as a team with them to give that dog a good quality of life. And determination of drugs effectiveness is often made over a minimum period of 3 seizure cycles. So just don't change drugs right away. Wait and see, and then slowly change. Knowledge is power, as you know. So there's some websites that you can go, and I think the last one is questions. I'm just going to stop right here. So International Veterinary Epilepsy Task Force is a good resource for you to go learn more. American Canine Clubs like Health Foundation Epilepsy Initiative is another one. Canine Epilepsy Network is a good one too. So you can definitely go browse these things, these websites, and gain some more knowledge. So what we'll do is I'm gonna stop sharing the screen and we'll take some questions.
Dr. Jha, thank you for this wonderful presentation. Before we go ahead with the question and answers, there is something which Vetina would like to introduce. And
Yeah.
Good evening, everyone. I'm Dr. Seema, and I would like to introduce you all with Vetina's anti-epileptic drugs. To begin with, we have the first product that is Vetina's potassium bromide suspension and tablet. The suspension is 250 milligram and tablet is 500 milligram. The composition is potassium bromide 250 milligram, cyanocobalamin 5 microgram, pyridoxine hydrochloride 5 milligram. It's in vanilla and butterscotch flavor. Easy to administer. Also, the tablet is 500 milligram of potassium bromide, cyanocobalamin, that is 10 microgram. It is a meat flavored tablet. So the acceptable, it would be very, very acceptable. Indications are seizures and anxiety. The dosage is to achieve a serum level of approximately 1 milligram per ml. You have to give 120 milligram per kg orally daily for 5 days and then reduce 30 milligram per kg orally once daily. Now, to achieve a serum level of approximately 1.5 milligram per ml, you have to give 160 milligram per kg orally for 5 days and then reduce to 40 milligram. So, as Dr. Jha has already shared with the dosage also, the detailed dosage is also available on our product leaflet. The description is Vetina's potassium bromide. It's in tablet and suspension. Our flavored tablet and suspension containing 500 milligram and 250 milligram potassium bromide respectively. By preferential movement across neuronal membranes via gamma aminobutyric GABA activated chloride channels, bromide may aid in controlling seizures through hyperpolarization. This has already been explained in the mechanism of action by Dr. Jha. Hypopolarization of neuronal cell membranes leading to stabilization and decreased sensitivity of epileptic foci. Then the indications, bromides are used both as primary therapy and as an adjunctive therapy to control seizures in dogs that are not adequately controlled by phenobarbital alone. While historically bromides were only recommended for use alone in patients suffering from phenobarbital hepatotoxicity, bromide are more frequently used as a drug of first choice. Presentation, we have the bottle of 60 ml and presentation of 60 tablets in one bottle. Next product which Vetina has introduced is gabapentin. It is 100 milligram tablet. The composition is gabapentin 100 milligram. Indication is again seizures, and gabapentin may be useful as adjunctive therapy for refractory or complex partial seizures or in the treatment of chronic pain in dogs and cats. Description, it is 100 milligram of gabapentin. It's a synthetic analog of the neurotransmitter gamma aminobutyric acid with anticonvulsant activity. The dosage is 10 to 30 milligram per kg body weight. Packaging is 1:10 tablet. The third product is levetiracetam. It's in 500 milligram presentation. The composition is levetiracetam 500 milligram. The indications are again seizures and epilepsy. It is an anticonvulsant that works by decreasing abnormal activity in the brain, helps to manage epilepsy in companion animals. The dosage is 10 to 20 milligram per kg body weight. The description is the product contains 500 milligram of levetiracetam. It's a drug within the pyrrolidine class that is used to treat various types of seizures stemming from epileptic disorders. Indications may be useful as an anti-seizure medication in dogs that are not well controlled with phenobarbital and bromides, or when either bromides or phenobarbital are not tolerated. In some evidence suggests that in dogs suffering from phenobarbital liver toxicity, the addition of levetiracetam will allow reduction of their phenobarbital dosage without increasing seizure frequency. So levetiracetam may also be useful as add-on therapy in cats also. With this, thank you so much. Dr. Jha?
Yes.
Shall we go ahead with the question and answers?
Yeah, I enjoy these kind of sessions for sure.
These
Talk is good.
products are now available with Vetina. So please do let us know if anybody needs the products. Just let us know. We'll be sharing the details of the products as well. So the first question, Dr. Jha, is what dose metro could cause seizures in dogs and cats?
Okay, well, metronidazole here is used anywhere from like 7.5 to 15 milligram per kg POTID. So if your higher dosage, like 15 milligram per kg POTID, would be probably at the level where you can see some, not seizure-like, but a little bit kind of like sluggish, sedative, not trying to walk properly kind of sign, which can look like a seizure activity. So I would say stay away from 15 mg per kg POTID, do a little bit less. So I will pick anything in between. My main go-to would be 7.5 mg per kg is what I would normally use, Flagyl.
Yes, the next question is from Dr. Tutika Ramesh Babu. If many seizures occur within 24 hours duration, what should be done?
Well, as discussed in the seizure control, the treatment, remember the slides where it was seizure and epilepsy. So you have to first treat the seizure. So if that's what is happening, I think at that point of time, patient should be in your hospital, should be on CRI of something known as Valium or diazepam. And we went over the dosage on that, which I can forward that to Vetina for you guys to review. So that's what you should be doing. If you can't control that, again, then the last resort would be to put it on a propofol CRI. But if it's general happening, reach out for diazepam, give an injection. If it keeps happening again, repeat the diazepam or put that dog or cat on diazepam CRI.
Okay, so Dr. Jha has already explained the dose rate of diazepam, so we'll not repeat that question again. And Dr. Gowda has asked, in spite of treatment, we do get seizures, especially on full moon day and also on no moon day.
Yeah, I see Dr. Marwa has also asked that
Asked
question.
the same question. Yes.
Yeah. It has been established. However, I would recommend that one of the researchers here, a neurologist, Laura Standback, has recently, when I say recently, it was published like about 10 years ago or so, where she looked at about 200 dogs and looking at the lunar phases. Is it Purnima, which is causing this or not? I mean, we all know about werewolves and how the wild dogs and wild go crazy around that time. And previously you would probably around those phases when there is full moon, you'll put those dogs on Valium to control. So it's something like, okay, there's thunderstorm coming, there's a level of anxiety, aggression, something is weird, behavior changes, and hence you will put that dog on tablets of Valium or any other kind of anti-convulsant. However, the study I'm talking about, and I don't know where it was published, but it was published by Dr. Laura Standback, and she looked at the lunar phases in dogs, 200 and I think 11 dogs or so. There was no significant difference compared to that versus in normal day-to-day life. So it is debatable. So it can still happen. I'm not going to say it's an old wives' tale, but it happens. So there's no harm increasing the dose of Keppra around that time, or just keeping Valium handy for those phases. Remember, one of the history and or the diagnosis was like weird kind of behavior change or aggression, anxiety, addition of something different at home can tip these dogs to go into seizure activity. So it happens. But scientifically, I don't think there is a correlation depending if you read that paper.
I would request everyone to please add your questions in the Q&A box. Then it will be easy for Dr. Jha to answer them. Because in chat, it's not easy for us to take the questions simultaneously. In the question and answers, you can just add your questions. Yes, doctor. Can we use anxiolytic drugs like clonazepam orally in epilepsy? It's a question from Dr. Mujib.
Yeah, I mean, anti-anxiety drugs have shown to show some effect, but it's not a mainstay and infrequently used for epilepsy. You can use it, but not one of the mainstay here in the United States, what I have seen. So you can definitely use for anti-anxiety, like one of those full moon days.
Okay. Dr. Ladit has asked, like, suppose how long the duration of this treatment should be continued? Means, like, till when?
Good question. If you're asking about AEDs, which is anti-epileptic drug, it has to be lifelong. So the thing is that, let's say you diagnose a dog and dog is 2 years old, golden retriever, has no structural issues, there's no metabolic and toxin which has caused seizure, or now you know it's epilepsy. Unfortunately, the dog has to be on epilepsy forever. The moment you remove it and one seizure happens, the pet parent and of course the dog will not be super happy. So most of the times it's lifelong.
Yeah. Anonymous person has asked, why back leg not used for test of blood glucose levels?
Okay. Well, I think that this was a question from Dr. Nigot also. So it's not that we tend to put front leg catheters here. So I think that was the protocol. So you can use anywhere. You can use ear or tailwind also.
Dr. Preeti has asked that pregabalin has not been spoken about. Can that be elaborated?
Yeah, so pregabalin, we discussed that in the gabapentin slide. I think you may have missed it. So it's 3 to 4 mg per kg, similar action like gabapentin, and you can use that. So nothing very special. One of the newer AEDs came after gabapentin, so another effective drug to be used. So it's a good drug.
If every hour the seizures occur, then how should we go ahead with the treatment?
Well, again, in nutshell, if seizure is happening every hour, that dog should be in your hospital. And the dog should have been getting some kind of CRI, which we discussed. Either you can use Valium, midazolam, propofol, anything, something like that. That is something like status epilepticus, and you can't control it. And it's an unfortunate thing that happens with our dogs. Really, really hard. As I gave the example where I fixed a portosystemic shunt in a Scottish Terrier, about like 10-year-old dog, nothing structural, but liver didn't like it. And then dog went into refractory seizures, and I had to put that dog for 8 hours straight on propofol CRI. So if that happens, then the slide I showed where, you know, if it's not stopping, you've given diazepam, just start that on diazepam CRI or reach out for propofol if needed.
Okay. So in the research articles, it's the full moon is expressed as X and the no moon is expressed as Y. So we have to start Y in complete dose, or we should gradually increase? That is a question by Dr. Sneha.
Okay, so X and Y, it will be a combination, and you shouldn't be like mixing and matching right away and stopping something completely and starting something very new. So it should be a weaning and slowly adding one to each other. And if this question was pertaining to the discussion I was giving, where I was asking that we should use 180 at a time, and if it is X and Y, then you know, the protocol I showed in one of the slides where you start Y with X, and then next 5 days you're gonna decrease the dosage for the X and continue Y, and then the next 5 days you decrease the frequency of X, continue Y, and then after that completely wean the X off and make sure that the dog is on Y, if that was for the AED.
Dr. Jacob has asked that what would be the mode of treatment when we get a cluster of seizures?
Okay, so it keeps coming back. So what we should do, if you're getting cluster of seizures, dog should be in your hospital. If not, admit the dog, put that dog on an anticonvulsant CRI. You can use anything, any anesthetic drug you have, most commonly is propofol. However, we reach out for diazepam CRI. You can do a midazolam CRI also.
Are there any nutraceuticals to just prolong or stop the occurrence of seizures? It's from Dr. Tayyab.
No, I'm not aware of those. Not that I'm like strong allopathic doctor or veterinarian. I do believe in holistic medicine, but I can't say that just because I don't know. So I don't know. Nutrition, food-wise, some omega-3 fatty acids and adding taurine has shown some efficacy.
Okay. Dr. Umesh has asked, can we use osmotic diuretic mannitol after treating cluster seizures or after resolving status epilepticus? Obviously,
Yes.
with the consideration to dehydration status of the pet. It
Yes,
did help me occasionally to bring down the restlessness and tachypnea. Can it be used routinely post severe seizure attack?
well, it depends how much of cerebral edema you're thinking that this dog will get. At times, I will do mannitol if I know that a dog has gone through a head trauma or has fallen and there will be some suspicion of swelling. So I'll use mannitol. So of course you can use that.
Dr. Manish has asked, what do you think about use of valproic acid in epilepsy?
I don't have any experience with that.
Okay. Dr. Sagar has asked, in 2 to 3 seizure cases, I found temperature above 105 degrees. How to manage such condition?
Yeah, I'll give you an example. A black Great Dane walked in the other day and was a known epileptic patient and was seizing, and temperature was very, very high. We removed everything from the treatment table. And normally the treatment table has a faucet with cold water, and we dumped a lot of ice and we put that dog in that ice to bring the core temperature down. Many other things you can do is hook that dog up to an IV saline with cold saline getting into the body, or you can douche the rectum with lots of cold saline, or cold water. So do not put ice, because that can cause problems. If that can cause injury to the rectal mucosa. So douching, IV, and then putting the whole dog in a tub of ice is what, these are some radical measures that you can take. Good question.
Dr. Nagendra has asked, if seizure frequency is once in 6 months or longer, then also should we start with AED?
So at least 2 to 3 cycles, as we discussed, that would be my preference. Because remember, these drugs have some issues or side effects. However, the new ones do not have that much of side effects. But I'll wait, and if it is just like once every year, I'll probably not put that dog right away on AED. But if it's more than like 2 to 3 within 6 months time or 12 months time, yes, they should go back on AED. We should start the AEDs.
How to manage myoclonic seizure in distemper recovered dogs?
I've not seen a distemper dog here, so I cannot answer that. But again, if it is a seizure activity and you just have to stop that, reach out for anticonvulsant drugs, which would be your diazepam and midazolam, and maybe a little bit of anesthetic if needed. But most commonly, diazepam, midazolam at like 0.5 mg per kg for diazepam and 0.25 mg per kg of midazolam IV should stop those.
Dr. Preeti has asked, in case like tick fever, we do observe epilepsy episodes. So diagnosis, do you recommend keeping the pet in AED? If yes, for how long? And how do we need to wean it?
AEDs are, I would say, mainly for one of the slides which we showed that the known cause. And one of the known causes is structural issue in the brain or idiopathic. Then the AEDs are long, because even if you remove the structural issue, like let's say go ahead and remove the brain tumor, there's always some swelling of the meninges or the surrounding area, which can still have the dog to be predisposed to get IE, which is idiopathic epilepsy. So you should do those. Now in tick-borne disease, you know that there's a tick-borne disease and you treat that. For example, let's put doxycycline and disease is treated. There's no seizure activity for next year or so, I would probably not put that on AED. However, if dogs is in an endemic area where there are ticks and you know that this dog will be bitten by that and will have these issues all the times, then it's a decision that you should be making with the pet parent.
Can we use Gardneril or Eptoin?
Are these generic name for drugs, or I need some little bit more information on that? So
can you add some information regarding this drug, doctor? Whoever has written this, the name is Uday Kumar, I think. Dr. Uday, please add the details here so that Dr. Jha can answer.
Yeah, as Dr. Uday is doing that, one question from Dr. Mara was like, like what are the simple basic diagnostic stuff that we should be doing for our pets in back home? So CBC Chem, UA, and then general neurologic exam should be done. I cannot not emphasize more on this. A good solid neurologic exam will give you some answer, will give you that there is a structural deformity. Again, that will be one-sided most commonly. And if you're doing a neuro exam and you see bilateral issues, then it's probably metabolic and toxin, because toxin do not choose sides. So do a good solid neurologic exam, run simple minimal database, which is chemistry, CBC, chem, and then UA, to get you some answers so that it's not necessarily all the time running and doing MRI and CT. I don't know if it's readily available. Again, I've been lucky that I see MRI and CT scan. It's in my office, in my hospital, and every hospital I have worked so far. But I know that many times back home, it's a little difficult to find and get that imaging done. So even you don't have to do a CSF. CSF to me is a little bit more advanced for an entry-level veterinarian to do because of some technical difficulty. For me, it's an easy task to do, but it will be a little difficult if you're not trained well. And plus, remember, CSF analysis will not give you a definitive diagnosis. So it's just can show you that there's something going on if you see neutrophilia, high protein, or some kind of weird bacteria in the CSF.
Dr. Gardneril is phenobarbital. Phenobarbital.
Yeah. Let's come back to the question. Okay. Oh, Gaikwad, sir, let me see. Hold on. So phenobarbital, yeah, I mean, very common drug used, still used very, very easily. I'm not that I'm a new generation veterinarian, but phenobarbital has been there for many years, 30, 40 years or so. But new drugs like levetiracetam, which we call Keppra right here, or gabapentin is my go-to. Phenobarbital affects or controls seizures or epilepsy really well. However, has a good liver side effect. So I stay away from that.
Dr. Arvind has asked, could you throw more light on motor and autonomic components of seizures?
So that would be something where motor activity, the first slide, what we saw, what we saw was there were convulsions going on. When I say where things are moving, basically. Okay, when I say autonomic, which is basically the sympathetic system has no idea what's going on and you're leaking urine or you're defecating. So when these two things are happening, you probably know that there is seizures going on. When these two things are not happening together, with the loss of bowel basically and motor activity and unconsciousness, then it's something else.
Okay. Can we use steroids in epilepsy?
Well, so in general, normal, I would say you suspect there's meningitis, which will happen, and there will be some swelling. Sure, you can, but it's not the mainstay of treatment. So you're just treating the other effects, which, so basically a supportive care. So it's something like, shall we use IV and other pain medications if needed? So something like that. But in general, if you're talking strictly about epilepsy, then yes, here and there, but I would probably stay away from that because now you're like adding one more drug, which will cause effects with the liver specifically, at times to the kidney.
In case of focal seizure, should we start with ADs?
Focal seizures can convert itself to like generalized one. So if that keeps happening at all times, sure, you can.
So there are questions like, can we get the copy of research article? So
You know what? That's. I think that you should read that article. So I'm gonna send that article to Dr. Tarokar, and she will pass that on. The main important article which I talked, which was. Can I share my screen quickly?
yeah, please. Also share your contact so that the people can directly contact you. Your LinkedIn or your profile.
Yeah, you can.
People can contact you.
You can definitely message me on Instagram. So drja.surgeon is my Instagram. So it's easy for you to do that. And then the LinkedIn is also Shanti.Jha. I mean, Shanti Jha is my LinkedIn account. So this is the paper, and I'll email Dr. Tarokar this paper, and she can distribute to everyone. It's an open access, so there's no like copyright or so. Very, very good, super good meta-analysis. So this paper has kind of like dealt with a lot of things, and the talk we're having a nice discussion here, but I think we should all read this paper. So let's see. So this is the paper I'm talking about, and I mean, it goes through all the drugs, what you will be using. It goes through all the evidences published by multiple, I would say, authors, and then talks about different drugs by, let's say, Booth, Chang, Cunningham, and then when they used what, was there any complications or not? So effects of AEDs, and then goes through a lot of other important information. So for example, you can see right here, gabapentin or pregabalin, how many studies were there. And then again, I'm not sure about all these drugs, which I don't use. So there were some questions about this sodium valproate. Again, I don't use that. And then in discussion is, again, a very important way where you can see. So I got this from this paper also. So please read this. It's a very good drug. And again, it recommends using AEDs. It talks about phenobarbital, one of the most important drug. The reason for that would be we have used phenobarbital for ages. So this paper is a little heavy on that. However, I prefer, as you know, is Keppra. So
Dr. Anil Kumar would like to talk with you directly, or he needs to have a chat regarding epileptic treatment. Okay, so
you can email me, and Dr. Tarokar has my email information, so that's totally fine.
Yes, I'll just share with him. Okay, so with this, I think treatment to continue, seizures stopped. If seizures are stopped, what will be the treatment?
If you're talking about seizures or you're talking about epilepsy, it's two different things, as we have discussed.
Yes. If the seizures are stopped, so what? What next?
The dog home, okay, 6 months later, he or she may have another seizures. You'll treat that again. But then if the severity is very high, very bad, and then the pet parent really wants you to put that dog on AED, as discussed, you should just start the AED.
Okay, so thank you, Dr. Jha. Thank you for this, the answers what we have given here. On behalf of the entire team of Vetina, I sincerely thank Dr. Shanti Jha, who could spend his time gracing his presence for the webinar. Today, we had the opportunity to gain information about epilepsy. This definitely has been very useful for all our young practitioners, as well as he has added more knowledge to the skills of renowned practitioners. I also thank all the wonderful participants for being a part of this webinar. So with this, I announce that the webinar is over. Thank you so much. Have a great evening.
Thank you so much, Dr. Jha, for such a nice presentation. Thank you. Thank you, Dr. Seema. Good.